and everybody kind of crossed their fingers and said, I hope you do okay. Maybe you will. I don't really know. But we're actually pretty good at saving people. What does survival mean in the ICU population? So survival means, I think, in the minds of you and I and most of the patient population, I go back to my baseline. But what we know is that the majority of the patients who are in the ICU actually don't return to their baseline. So PICS, which is post-intensive care syndrome, PTSD, physical debility, and cognitive debility are all things that are fairly common in the ICU, post-ICU population. And these are things that I don't think that we as a medical community are doing a great job of talking about with patients or understanding how that's going to affect our patients in the long term. So 50%, and these are people who are on mechanical ventilation for 48 hours or longer. And I want you to think about that, 48 hours. It's not very long for a mechanically ventilated patient. I think if I go in and a patient's on mechanical ventilation for 48 hours, I think that that's a pretty short vent time, right? Vent days of 2 is not long in my book. But of those patients, 50% have some degree of ICU acquired weakness, meaning debility in performing basic ADLs. 50% have cognitive dysfunction, and 30% have some sort of emotional lability, anxiety, PTSD, etc. So I like to talk about patients. I'm very patient-centered, so we're going to start with the patient. So this is Darrell. He's a 51-year-old engineer. He lives in rural Kentucky with his wife, who's a school teacher. He's not overweight, but he has a congenital sort of defect in his knee and had one knee replaced a few years ago, really great success, and so I decided to have his second knee replaced. Non-smoker, pretty active, all the things that you'd think this is going to be a super easy knee replacement, right? He actually goes to our sort of sister hospital where we do our outpatient surgeries, has his knee replaced, and in the PACU gets super hypoxic. Everybody thinks, what's happening? He's placed on oxygen in the PACU, and they get a chest x-ray. Doesn't look good, right? So we have a problem. He continues to decline. He's brought to the MICU. He has a central line placed. He's intubated. So we bring him over to our hospital. He has a bronch, and we find diffuse alveolar hemorrhage everywhere. And if you've ever been involved in joint replacements, they anticoagulate him. So then we stopped his anticoagulation because we said he has DAH. So over the next 24 hours, he gets more hypoxic. He develops ARDS. He develops shock. He gets prone. He gets paralyzed. He gets super high-dose steroids. Here's his CT scan. This is a routine knee replacement, right? So he developed a ventilator-associated pneumonia. Of course, he got a DVT, despite the fact that we tried really hard with IVC filters and bicycle machines on his legs and things of that. On day 22, he got a tracheostomy because he just could not come off the vent. He was so weak. He got a pneumothorax. He had chest tubes. He was in the ICU for 35 days. I mean, it's a long stay, but in our institution, 35 days is not necessarily horribly uncommon, right? So now here's the next piece of this that we have to think about with these patients. So yay, day 35, he has a trach, a peg, a chest tube, and I go in and tell his wife, it's time for you to go to the LTAC. Aren't you excited, right? And she says, what are you talking about? You're sending me to a different facility, to a different set of doctors. Where are you going? What's happening? How am I going to communicate with them about what's happened to my husband? He had 10 new medications, and he took a couple of meds before he came in, but he was really a pretty healthy 50-year-old guy. So he couldn't walk, couldn't talk, he couldn't sit up, and he had absolutely no memory of what had happened to him. And when he was in that phase of sort of ICU recovery, where you go and you talk to them, and you're like, hi, and they like look at you, and you're like, oh, yeah, they're there, but they're not, right? And his wife just cried at the bedside almost every day. So on hospital day 63, he left the LTAC, yay, and went to a rehab hospital, in acute rehab facility, right? He has 12 new medications. He can't walk, can't feed himself, he can't go to the bathroom by himself. He'd seen 16 different providers in 63 days. And of course, you all know that every one of us had an opinion on how things should be changed or modified, right? It's all written down in some long electronic medical record at 3 or 4 different institutions. He has no memory of what has happened. And he's complaining of being anxious and depressed. And everybody says, oh, no big deal. That's okay. Aren't you glad you survived? So on hospital day 85, so 85 days after he goes in for a routine knee replacement, he's discharged home with his wife. And she talks to me still about this day and the terrifying feeling she had in the pit of her stomach when they left that acute rehab hospital. He's on 17 new medicines. 17. I can't remember to take 3 medicines, right? 17. He couldn't walk. He couldn't feed himself. He can't go to the bathroom independently. And they say, yeah, you're ready to go home. Aren't you excited? He has no memory of being at any of the previous facilities. He cannot tell you anything that happened there. He's anxious, depressed, and he tells them, I'm having these horrible nightmares, right? So his wife is supposed to go back to work in 12 days. She was a school teacher, so they did this procedure the end of May so that she would be off for the summer. She's supposed to go back to work in 12 days. He can't walk and he can't go to the bathroom. Yay, you survived. So as we as medical professionals have improved our care of patients and have improved the number of invasive, life-sustaining treatments, we've increased our survival and dropped our mortality, which is good in general, right? But the problem is that a lot of these patients that survive don't ever return to their baseline level of functioning. Or, as I talk to the patients about all the time in the recovery clinic, they have a new normal, right? It's not that they're not at baseline. It's just that things in their body and their brain function differently after an ICU stay. So we as the global we as the healthcare community have recognized that this constellation of symptoms needs a name, and as every good thing in medicine needs, it has to have an acronym, right? So we call it PICS, Post-Intensive Care Syndrome. And this is defined as new or worsening impairments in cognitive, physical, or mental health that impair your return to work or quality of life and are there at 3 months, right? So post-intensive care syndrome. The other piece of this that's also interesting is we know that a lot of times the family themselves will also have some of the post-intensive care syndrome things. And, I always tell the residents and the fellows when we're on rounds, I want you to think about the differences between war and being in an ICU bed, right? You're tied down. People are jabbing things in you. You have no prediction. Your brain can't understand, why does this person keep coming in these blue scrubs and jabbing things in my arm? Why is this thing shoved down my throat? We're giving them all these mind-altering medications to keep them calm and to keep them sedated. So many of the symptoms that these patients begin to feel after the ICU are PTSD-like. They have hyper alertness. They have fears and nightmares that they can't control. They're jittery and confused about what happened. And if you think about it from just an outsider's perspective, it is very similar. They're completely out of control and unable to predict when harm or discomfort may occur to them, right? And are fearful for their life. Those are the things that sort of define that syndrome. So up to 50% of the people that you discharge from the ICU are going to have symptoms in one of these domains. And I think we think, oh, so they have a little anxiety. But this isn't a little anxiety. This is life-altering anxiety and PTSD. Oh, so they have a little physical dysfunction. And this, for the majority of these patients that we're talking about, it's not just a little. It's, oh, I can't use my right hand. Well, if you're an engineer working in a factory and your job, as this guy was a machinist and he went out and he did drawings and changed the dynamics of these machines, he couldn't do his job anymore, right? I mean, these are life-altering experiences. So we divide risk factors for PICS into 2 categories, sort of the ones we talk about as ICU related and as patient related. And we think about the ICU-related factors as things that we do to the patient, right? So this is, how long were you on the vent? We know that if you're on the vent longer, you are more likely to have PICS. How many body organ systems did we replace with the machine? Did you get ECMO? Did you get a CRT? Did you get shock? Did you get a paralytic? Each time you're walking past that patient's room and you're adding one of those things, you are increasing the chances that this patient is going to develop PICS or some symptoms of PICS. Hang on. Did it change? Okay, there we go. Sorry. And then we have our patient-related factors. And this is just a fancy way of saying comorbidities, right? So if you're older, if you came in with a lot of things, a lot of comorbidities at baseline, you're obviously less likely to survive and have a return to your previous function. I always try to think about the body as sort of a homeostasis of machines and things working. And so if I hurt my leg, my other leg can take up the slack while it heals. Well, if my kidneys are already failing before I ever get to the ICU, then they're not going to have the ability to take up any of the slack while my liver is healing or while I'm trying to repair my DVT, right? And if I'm already debilitated and in a wheelchair, or I'm already have some level of cognitive decline, then I'm going to have less ability to recoup from that initial injury that occurs in the ICU. So we know that some of these symptoms can come up immediately following a patient's ICU stay, and with interventions can improve, right? We can help physical debility with physical therapy and occupational therapy. We can help cognitive dysfunction with occupational therapy, with some games and brain testing and neurocognitive intervention. We can help depression and anxiety and PTSD with some medicine, some lifestyle changes, with things of that nature. But we also know that many of these patients have symptoms that persist for years, and for many of them forever. Darrell talks to me all the time about his new normal, and that, you know, the day that he realized I'm never going to be the same person that I was before I went to the ICU was one of the hardest and best days of his life, because he had sort of accepted that the attempts he was making to regain all of the life he had before were never going to be successful, right? Sort of like the day I said I'm never going to run a sub 7-minute mile, and that's okay, right? So I have to work for that goal anymore. So we know that there are things that affect patients' long-term outcomes, some more than others. 85 to 90% of patients that have ICU acquired weakness on discharge have symptoms 2 to 5 years later. So we know that that physical disability that we all see, this is, you know, you walk into the ICU room, they can't lift up their arm, they're sitting up on the bed with the physical therapist. This is a grown human, right? And they can't even sit up on the bed, and their wife's like, oh, you know, they went to work 6 weeks ago. So that weakness that we see that occurs really does affect people, not just in the acute ICU setting and not just in the rehab setting, but 2 to 5 years later, people are still having symptoms. So long-term clinical manifestation. So you always talk about what you see in the ICU, and then how does that affect the patient long-term? Where are we in 2 to 5 years? So from the physical domain, we always talk about ICU acquired weakness, dysphagia and pain. Lots of patients complaining of problems with swallowing, changes in vocal cord, posterior pharyngeal anatomy, and vocal cord injury, leading to dysphagia, leading to vocal cord paralysis, all those sorts of things. Cognition. So the big parts of cognition that people complain about are memory, planning, and attention. And those are those pieces of cognition, I think, that you and I take for granted. Most of us in this room have never struggled enormously with these things because we've come pretty far in our academic life, right? We're trying to cram as much stuff as we can into our brains, but we're not necessarily talking about higher level functioning here. We're talking about the fact that they can't go into a crowded room with people talking and maintain a conversation, right? Darrell always talks to me about the fact that he struggles at places where he knows lots of people, the church or the grocery store, because when he walks in, 2 or 3 people will talk to him at the same time, and his brain is not capable of focusing on one person and saying, hey, hang on, I'm talking to Johnny, I can't respond to you. It just hears all this noise at one time, and then he becomes anxious again, right? Because he feels like he's going to fail, leading to anxiety, depression, and PTSD-like symptoms. So ICU acquired weakness. So this is clearly defined, yet another beautiful set of letters that we can label somebody with. So this is defined as weakness that occurs as a direct result of being in the ICU. So there's lots and lots of people doing research on this, and we talk about critical illness myopathy, critical illness polyneuropathy. the end of the day, it doesn't probably matter what the innate cause is as much as what are we going to do about it long term and how are we going to help patients, right? So we know that just being on a pressor, we know that just being on a ventilator for a very short amount of time has global effects on your muscle function. It has effects not only on your diaphragm function, but on your quadriceps function, on the muscles in your hands, on your fine motor skills. And all of this is just propagated throughout the ICU stay when we sedate people, when we put them on high doses of steroids, when we tie them down in a bed so that they physically can't move, right? I mean, I do it, I understand, which is the balance of trying to keep the patient safe. But if you think about, step away from the bedside and think about what we're doing, you understand how that could lead to ICU-acquired muscle dysfunction. And it's just exaggerated when you add on pressors and shock. We know that part of it is the things that we do, and part of it is a cytokine-driven piece of it too. In laboratory animals, there's been some pretty significant modeling done where they take animals and just give cytokines and can induce some of this. So it's not just about being immobile and receiving artificial drugs and things. It's also about your body's response to critical illness in general. So the other piece of this, I think, that I always sort of go back to is my focus is always on the patients and on the people who are in the beds and on what's going to happen to them and their families long term. But from a resource utilization, I'm sure you guys are struggling just as we are with how to take care of the vast number of people who are flooding in our doors, and we're all being regulated on, do you have readmissions, 30 days, and da-da-da-da-da, right? So we know that people who have ICU-acquired weakness in the 30, 60, and 90 days post-ICU discharge have increased resource utilization within their healthcare systems. That is a known fact. And as you can imagine, if you can't walk and you can't sit up and you can't brush your own teeth, you are going to have more resources for you to stay at home. And if you can't stay at home, then you're going to have resources to go somewhere else. So ICU acquired weakness. In the critically ill patient, we know that there are some things that are very evidence-based for causing this, right? So the things that we know can cause ICU weakness and we have direct evidence of: tight glycemic control, shorter time of mechanical ventilation. So we know that if you control people's glucoses and you don't allow them to get super high, we have less ICU-acquired weakness. We also know that hypoglycemia is super, super bad for people in general, right? It's now one of the new Vizient modeling measurements is, did you get insulin and get hypoglycemic? Because we know that's bad. So there's a balance here, right? Where is that line? We don't necessarily know. And we know that every day you're on the mechanical ventilator increases your risk of global muscle weakness. And I'm not just talking about diaphragm, I'm talking about arms, I'm talking about neck, I'm talking about quadriceps. So some evidence, it's controversial, some people, I don't know that it's that controversial, but corticosteroids and neuromuscular blocking agents. Well, a lot of our patients get paralyzed, okay? You come in, you have ARDS, I can't oxygenate you, you get paralyzed, it's what happens. And corticosteroids, I feel like every patient in the hospital is on steroids at some point. When all else fails, give them steroids. So a lot of people on steroids, which we know can contribute to ICU acquired weakness. So possible evidence for benefit is early mobilization and sedation sparing protocols. So, and this makes sense, right? This isn't fancy. This isn't, I always talk about with my residents about sexy medicine and non-sexy medicine. This isn't really that sexy, right? This is get them up, get them moving, and don't sedate the dickens out of them, right? Let their brains experience the world. It's not as fun as ECMO, I'm not going to lie, but it works and it helps long term. And then the theoretical benefit, we all talk about optimizing nutrition, we all talk about electrolytes, but none of that's really been shown to have good long-term outcomes or good any consistent validated long-term effects. And so I would argue that chasing electrolytes may not give you as much benefit as just getting them up and getting them moving and getting them off the vent faster. So delirium, this is another thing that we know a lot, almost all of our patients in the ICU experience to some level, right? And if you imagine what's happening to the patient, I'm pretty sure I'm delirious just after working 12 shifts in a row, right? So you can imagine living in the hospital going into the room every day, the patient's sedated, they're on all these machines, and then we slowly wake them up, and then we don't want them to pull out the tube, so we might give them a little other kinds of sedation to keep that from happening. There's so many different variables involved in this. But we know that in patients with delirium, it's not just about that acute incident. I think we all are like, oh, they're delirious, no big deal. But we know that being delirious in the hospital actually increases your chances of dying, right? And when they do regression analysis, it's not about comorbidities. It's not about any of that. Having delirium in the hospital increases mortality. So, and there's lots of types of delirium. I'm not going to go into in grave detail, hypoactive and hyperactive, the patient who's all over the place versus the patient that's just kind of laying there and doesn't know. Those are both brain dysfunction, and that's really what delirium is, right? It's a kind of brain dysfunction. Changes in psychomotor activity, disorientation, and fluctuations in presentation. So I like this picture. This is one of the, I'm involved in the Society of Critical Care Medicine in the Thrive group, and we sometimes have patients come talk to us, and this patient was an artist and was in the ICU for, I don't know, a month or so for an ARDS-like picture. And this was what she drew. And she said, when I went home, this is what I thought I saw every day. So like there's the light on the ceiling. There's me, right? Yeah, I'm not sure. Yeah, I don't know what this is. But I mean, really, and if you stop and think about it, you're like, oh yeah, I see the IV pole. There's that tower over there with all those lights on, right? Here's this person that comes in. But I mean, look at this. This is insanity, right? It is. But this is what they felt and saw. So why does delirium matter? As I said, each day a patient's delirious increases their risk of death by 10%. Not just increases their hospitals, not just decreases their long-term functional outcome. Death, it's pretty impressive. So cognitive impairment rates go up, long-term outcomes are depressed, and let's go back to resource utilization. It increases hospital costs and length of stay, right? So all bad. And we think about this as an ICU-related variable. A lot of times there are probably patient factors, but the question with delirium is always, is it a cause or is it an effect, right? We know that if you have dementia coming in, you're more likely to experience delirium. We know that if you receive benzos in high doses, you're more likely to experience delirium. But there are things that we can modify, right? So I can't change your age. I can't change your baseline comorbidities. I can't probably affect whether or not you have sepsis. I can't affect your hypoxic level. But what can I do? I can, when I begin to wake you up and bring you back up to cognition, I can turn off the lights at night. I can restore circadian rhythms. I can do things. This is one of my favorite things that we talk about sometimes. So we all learn in medical school about, you wake up in the morning, your cortisol spikes, your insulin levels all change, right? You go through your day, all that happens. And then at night you go to sleep and things change. We don't allow those normal cycles to occur in the ICU, right? So we keep you up, we poke you all night, there's lights on. How many of you round at night, you walk down the hallway and the TV's blaring in the room and they're like, yeah, I was delirious, so I turned on the TV. You're like, that's not what we should be doing, right? We also put people on tube feeds and we feed them continuously. They have no spikes in their cortisols and their insulins in appropriate levels because we don't allow it to happen, right? Little bitty things, not expensive, not sexy, I know, but still could affect people long term. So, and we know that medications in our clinic, what we do a lot of is medication management. So looking at anticholinergic scores, we know that the more of those medications people are on long-term affect them. But we also know that those medicines have effects directly during their ICU stay. And looking at those medicines and saying every day, do I really need this? We round all the time. I do this as well. And you go through and you're like, oh, they're on pressors, they're on steroids, they're on antibiotics. But nobody notices the PRNs at the bottom of the sheet where they're getting Haldol and Seroquel and all these other things so frequently. That actually may have more of an effect, right, than day number 9 of your antibiotic. So ICU delirium. So things that we know that we can do. We're real good at sedating people, and we're learning in the ICU that people actually experience a lot of pain. I mean, kind of makes sense, right? Jab them and poke them and do all these things. And that for the human body, even in a semi-sedated state, pain actually does have significant catecholaminergic responses. So treating pain first in the ICU is one of the things I talk about. When you walk by and the patient appears agitated, instead of giving them benzos, instead of giving them more propofol, try a little pain medicine. Try some Tylenol, right? I mean, try an oxycodone orally. That would be a better option than increasing the propofol drip. So avoiding benzos, I think everybody knows this information at this point. Obviously, there are patients when you have to use it, but in general, trying to avoid large doses of benzodiazepines because we know that they decrease long-term outcomes. Monitoring for delirium. So this is another thing a lot of ICUs are doing now, or used to not do, I should say, is just monitoring, asking your nurses to calculate scores for delirium and looking for that in your patient, right? I think as patients begin to wake up, when we get through that sort of acute illness phase, the next step is, okay, how am I going to get this patient from acute illness back to baseline? And what can I do in that period? That's the patient that we were all there. You're rounding, you're like, oh yeah, they're on autopilot. We're just moving through this phase with them. But we're really not. We need to be looking at all of these things and trying to figure out how we're going to help them long term. So also things I always tell the family members, the minute they wake up, okay, we're going to get on a sleep cycle, we're going to get on a feeding cycle. I also want you to interact with them. Bring in a book and read to them. If they talk, go to the bedside, get into their face where they can see people they recognize and say, yep, you're in the hospital. It seems crazy, I know, you're very sick, I'm here. Repeat the same things over and over, orient them, bring in their glasses, bring in their hearing aids, all of these things. And reducing noise in the hallways is another thing. Patients are in a bed, strapped down and tied down, and there's all this chaos going on around them. And we know that a lot of times that chaos gets incorporated into their PTSD and anxiety. So all of the delirium literature supports reducing ambient noise, the beeping, the Zamboni guy who's cleaning down the hallway, all of that. So where do I go after the ICU? So this is, you're better. And your choices are the LTAC, the rehab hospital, the nursing home for subacute rehab, stay in the acute care, go home with assist, or go to hospice, right? These are the choices. And a lot of times, these things are not necessarily based upon what the physician or the provider thinks, but on a communal approach that includes, at the end of the day, what kind of insurance you have, right? So we know that in the LTAC, you got to meet medical criteria. So you got to be sick. You got to have a trach. You got to have wounds. You have to have profound issues with mobility. You got to have new dialysis. You have to have a new PEG tube. Got to have long antibiotics that are frequent dosing, things of that nature. Many of my patients don't meet LTAC criteria because although they're confused and profoundly weak, they don't have a medical need, right? So you think, well, we'll send you to an acute rehab hospital. Well, the problem with the acute rehab hospital is, one, you got to have insurance. And two, you have to be able to participate in 4 hours a day of PT and OT. So if I tell you, oh, sure, my patient's super weak, but they have a little cognitive disturbance, they're going to require a sitter to help redirect them, well, then you're pushed off that, right? So then maybe you're going to the subacute nursing home facility, right? You got to have payment. You can't have a trach. You can't have profound weakness, and you can't have any behavioral issues. We're having a problem here, right? So then they wind up staying in the acute care hospital because I can't get them anywhere, which in our ICU, we do PT, OT about every 3 days. We have trained people, that the same group that work with us. But once they move out of the ICU into a floor bed, the PT, OTs become pretty scarce, right? It's just not what the acute care hospital is set up to do. So then you're like, okay, well, they'll go home with assist and home health will come, which is a reasonable option. But who is assisting? I told you, Darrell, who is a fairly affluent human being and had lots of social supports, his wife had to go back to school. She's got to work so that they can continue to have insurance and all the things that they need to take care of him. And then you're like, hospice. Okay, great. Well, but I'm not ready for that, right? I know I need a new hospital bed and can get it, but that's not really my best option. The other problem with all of this is that there's very little communication between these agencies, right? So my patient leaves my ICU and heads off to the LTAC, where a different group of nephrologists, a different group of ID doctors, a different group of pulmonary critical care doctors, and a different group of respiratory therapists and physical therapists are caring for them. And they may read the glorious electronic medical record notes that are sent, or they may not, I'm not sure, right? And then from the LTAC, the patient and the family are handed some pieces of paper, right? Here's your discharge summary, here's your medication reconciliation, and then they go to the next step where a different group of doctors that has different priorities, right? And each place you go, the physicians and the providers are trying to take the patient, make them fit in their box, get them through the door in the right number of days, and send them on to the next level, right? So as you can imagine, families tend to be very, very overwhelmed by this process. So next patient. This is David. David is also 51. 51's a bad age, I guess. He's an executive at a local company, non-smoker, social, alcohol, BMI is 20, and he's an ultra-marathon runner. And by ultra-marathon, I mean like 70 to 100 miles. He's an insane runner, right? So he was out running and got bitten by a dog. 2 days later, he had some fatigue, a fever. He came to the ED, but just like everywhere, the ED was booked. He sat for 4.5 hours in the lobby because he wasn't critical, and then said, forget this, I'm going home. The next morning, his wife finds him non-responsive in the bed and brings him in. Did I miss one? No. Here's his X-ray and his CT scan. So he had septic shock. He had AKI requiring emergency RT. When he got there, his pH was 6.9, and he's not a diabetic, right? His CT head had diffuse edema. He had DIC and a heart. Suppressed LV, right? He ran 12 miles 72 hours before the submission. It was pretty impressive. So David actually had fallen out of a tree when he was a 14-year-old or something and had a splenectomy. And somehow the concept had eluded him or his primary care doctor. He had never really been told that he was at increased risk for things, or he'd never heard it. I don't know. He was a 51-year-old who was pretty healthy. Maybe he just didn't go to the doctor a lot. But he and his wife were pretty vested in their health care. So, but he grew capnocytophagia, which is a common bacteria from the dog, oral flora, and because he was asplenic, was at high risk for this. So he had a feeding tube, he had dialysis, he had an art line, he had a central line, all the things. He also, because of his cardiogenic shock component, lost a lot of his fingers and toes initially, so had a lot of eschar and ischemia that day. He spent 12 days on mechanical ventilation. On hospital day 26, he's discharged. He actually didn't need a trach, which I was a little concerned about because I thought they weren't going to take him to the LTAC, but he had tunnel dialysis catheter and new dialysis needs, and so that got him the LTAC bed, like this game, right? He was on 12 medications, and he couldn't hear anything. Like he kept telling me, I can't hear you, can't hear you. And he couldn't write anything down or tap with his fingers because his hands were ischemic and swollen and he couldn't really move them. So he had very little communication. We figured out a way to communicate where he would take his elbow and point to the board and we would write letters down. It was more than a little frustrating for David. So on day 48, he goes to the LTAC, or goes from the LTAC to the rehab hospital. So yet another transition, right? Here we go. He has complete hearing loss in his right ear. He says he's exhausted. He's seen 14 physicians and is on 10 medications. He was on no medication prior to 0. So, and he couldn't walk. So, Projectory, right? ICU, LTAC, rehab hospital, home, yay. So, many ICU patients, when they get home, and you can imagine, I think I've painted this picture, they get home, they're debilitated, they're on tons of new medications, and they don't know why, right? And honestly, sometimes I don't know why they're on them either, right? So they show up in the clinic, and I'm like, why are you on this? I don't understand. It's because it got started, and nobody knew why, and nobody wanted to stop it, and so they just kept going, right? It could be something. So they have cognitive issues, physical issues, and mental health issues. So you can imagine. They can't follow direction. So they're given a med rec and said, take all these meds. They can't follow the directions, and they can't remember the directions from the time they left the kitchen till they get to the bedroom to find the bottle. It goes pretty well, right? They can't bathe, they can't dress, they can't walk, and yet we've sent them home and said, you're better, and your family can deal with this, right? I'm a physician, and I see some of my patients get discharged home, and I think, I'm not sure I could do that. And it's not just about the actual physical engagement. It's about the size of the patient. It's about how big is your house? Where's your bedroom located? Where's the kitchen? Where's the bathroom in relationship? Can you get them into a bathtub, into a shower? They can't sleep. They're anxious. It's like having a child at home again, right? That's what a lot of my spouses talk about. So they have complex needs. So you've got to transport them to physical therapy, or the physical therapist is coming to the house 3 times a day. Who's going to be there to let them in? Do I need to be there? Can my family member be there by themselves? They can't drive. They have 1,000 doctor's appointments, right? Because as good internal medicine physicians, we all consult 50,000 people who all think that they need an outpatient clinic follow-up in 6 to 8 weeks, which really becomes 10 to 12 weeks, right? And then nobody knows why you're scheduled to see 2 different ID doctors. That happens a lot. And the family relationships are strained, right? Darrell went from, I'm the primary breadwinner in our household. I go to work, my wife's the school teacher, and she's got summers off and all of this stuff, and kind of takes care of our kids and our grandkids, to I can't even go to the bathroom by myself, never mind return to work. The other thing that I would say is that a lot of the primary care practices are not equipped for this, right? Primary care, and was an interesting article, I think it was in JAMA or was in New England Medicine, I can't remember, where they talked about the time spent with the patient. So a primary care doctor who is supposed to cover everything, right, on average spends 5 to 8 minutes with the patient. Whereas a specialist who only covers one organ system, on average, spends 10 to 12 minutes with the patient. I don't know about you, but I spend more than 10 to 12 minutes in the line at the grocery store. What is this we've come to, right? So they show up at the primary care doctor, and they have this enormous chart and all these medicines. The patient doesn't really know what happened. The family can't really tell them what happened. And the primary care doctor is supposed to weed through all of this, figure out what the next steps are and where they're supposed to go. So, and I'm guilty of this. We don't talk to primary care doctors. How many of you all who have a patient in the ICU pick up the phone and call the patient's primary care doctor when they get discharged and say, they're getting discharged. Hey, these are the things I think are going to be important. Do you have questions? Do you want to communicate about this? We don't. And the clinic communication is not great anyway, so. I always like to talk about, can you imagine having a stroke and not getting referred to see a neurologist afterwards, or having an MI and not getting referred to see a cardiologist? No, I mean, that's sort of standard, right? But if you go to the ICU, we just send you back to your primary care doctor. We may send you to all of these as well, but nobody's running the show. No central person is managing the care of these complex patients. So this is where the concept of the ICU follow-up clinic or the ICU recovery clinic started. I think it came from the fact that many of the intensivists who are also pulmonary critical care docs were seeing these patients return to the pulmonary clinic. I think many of the nephrologists were seeing them return to the nephrology clinic and saying, who's managing this? Who's running this? And so people began to recognize that there was an innate need for somebody to help these individual patients manage their post-ICU care, right? And the concept is that somebody familiar with what actually occurred in the ICU might do it best. When I see these patients afterwards, I've met them in the hospital, I've met their families, and I'm familiar with their whole case and can help manage that. So the first clinics were established in the United Kingdom more than 20 years ago. And in the United Kingdom, every patient who's seen in an ICU gets referred to an ICU recovery clinic. Everyone, they go. And they're run by nurse practitioners with some physician leadership. And it's more about just helping the patients navigate that system and deal with the PICS symptoms. The first ones at US were the Critical Care Recovery Clinic at IU. And the second one was established at Vandy in 2012. And then the model for these is always transdisciplinary. So it's one of the things I talk about. This isn't a clinic where you go in and the most important person in the room is the physician. It's hard to stomach for some of us, I know, but it's not, right? Some of the patients come in and they need to see me, and we need to talk about trach management and chest tube management. But some of them don't. Some of them, the most important person in the room is the pharmacist, helping them acquire the medicines they need, or helping tell them, you don't need to take these, or don't take that supplement your brother-in-law told you to because it's going to contradict with this, right? Some of them, it's my physical therapist who's helping them figure out what they can do on their own to regain work and physical function. Some of them, it's my occupational therapist who's helping them learn to drive again or how to fill out a checkbook again, right? Some of them, it's the social worker. So it's not always the physician who is the most important piece of the ICU recovery clinic. There has to be one to help lead better. There's currently no standard of care or ideal model for this. We're working on that through the Society of Critical Care Medicine. But the goal is to improve the quality of life of the patients, to decrease readmissions, and to decrease healthcare resource utilization. And we actually, so there's some people in the, through the Society of Critical Care Medicine, we have ICU Clinic Collaborative. So there's several of us around the country who are doing ICU recovery sort of models, and we sort of collaborate once a month and talk about stuff. And one of the groups is out of Ashkenazi, which is a group in Pennsylvania, and they have a closed healthcare system. So part of what we struggle with these patients is Medicare and Medicaid only track patients for 30 days after they leave the hospital. Well, you can see from both Darrell and David that at 30 days, they were both still in the LTAC, right? They hadn't even left there. So yay, they didn't get readmitted in 30 days, but I don't even know what that means. So Ashkenazi, because they're a closed healthcare system, all of their patients see all of the same physicians within the unit, so they can monitor them. So they showed some profound reduction in healthcare utilization and cost to the healthcare systems in the patients that came to the ICU Recovery Clinic versus did not. And that information is going to be published coming up very soon. So I'm hopeful that that's going to also help with the administrators and understanding that this actually may benefit all of us. So for the University of Kentucky, I established our clinic in 2013. This says occurs 2 to 3 times a month. It actually occurs weekly now. So I have a physician, a pharmacist, nurse practitioner, a palliative care person who is there intermittently, a physical therapist, an occupational therapist, and a social worker now. So it's very, very multidisciplinary. So this is sort of how we do it. So the initial appointment happens, and I try to schedule the initial appointment the week they come home from a hospital. So whatever that hospital is, I try to have them come. So if they get discharged on Monday, I want to see them that week or the following week, because that's the week when they get home and the family goes, oh no, somebody else has been helping give me my medicine. Somebody else has been turning me. Somebody else has been doing all these things. And now I'm not sure how to do them myself. And those are the weeks we figured out. In that first 10 days home, the readmissions or the trips to the ER are enormous because people are just overwhelmed. And then I see them at 3 months, 6 months, 9 months, 12 months. And then the goal is to get them back to their primary care doctor. I'm not trying to be their primary care doctor. And as we move through the system, sometimes I see people more frequently or less frequently. But in general, the whole plan here is that they go back to the person who is in their rural community. So initial appointment. The first week they get home, it's a 60-minute appointment. I schedule them for 60 minutes, right? This is not a 12-minute primary care doctor appointment at all. So we do medication management with our pharmacist. We do MOCA cognitive screenings. We do screenings for PTSD, anxiety, and depression, and we have referral systems for all of that. We discuss PICS. We talk a lot about families, and then we get some baseline labs and imaging if I don't already have those, right? And then at the 1 month appointment, we start talking about, do you need to go to pulmonary rehab? What's your 6-minute walk? Do you need some counseling? Do you need some support? What's your spirometry look like? What do I think you're going to need? You're going to be able to go back to work? Do you need help with your disability paperwork? So it's a lot of primary care, social work, physical therapy, occupational therapy, and it's all multidisciplinary. We set it up, we have a board, each person goes in the room, and then we come out and we discuss the patient as a team and how can we help them, right? And then 3 months, 6 months, and 9 months. So who do we currently invite to the ICU Recovery Clinic? Because we can't invite everybody. Anybody on mechanical ventilation greater than 3 days, anybody who has a new trach, a new PEG, also any new organ system failure. So if you didn't have dialysis and now you do, or you were discharged with dialysis, even though you'll find out David didn't. Anybody with ICU acquired weakness, anybody who's diagnosed with ARDS, anybody who goes on ECMO now at our facility gets referred here. So all the ECMO patients are coming. And anybody less than 40 or older than 70. And the older than 70 is because I find that that group of patients has a lot of other issues going on frequently and a lot of pre-medications and comorbidities. And the under 40 is because they have no social supports. They weren't sick before. They don't know who to depend on and how to set all this up. So it's a lot of collaboration with the PCPs. We actually call primary care physicians and we ask patients on their first visit, do you have a primary care doctor that you like? If you don't, can I help find you one? because I'm in the internal medicine department and the residency, I know a lot of the people who leave and go out in the rural community. And so when I have residents leave, I say, I'm going to send you ICU Recovery Clinic patients. Know that. And then I'll call them and talk to them, and they're familiar and we have a good relationship. I also find that 10 minutes on the phone with a primary care doctor can make the primary care doctor completely comfortable with what's happening with the patient. And I give them my cell phone and I say, here's my email and my cell phone. If they show up in your clinic and you need help, please call me. Let's try to work together to help this patient so that they don't have to drive all the way back to Lexington. How does it help the system? So we're trying to avoid unnecessary referrals to physicians, right? So just because you had AFib while you were in the ICU, critically ill on 4 pressors and prone, doesn't mean you need to follow up with cardiology, right? But almost all of them get that. And they come to me and say, do I need to come up to Lexington the next 5 days in a row for this, right? Just because you had diabetes and somebody consulted, do you have diabetes, and someone consulted endocrine, doesn't necessarily mean you need to come up and see the endocrinologist in Lexington. Your primary care doctor has been managing your diabetes just fine for the last 10 years. Your A1C was low when you got here. You're not having elevated blood sugars. Why would you need that? But somebody has to be able to tell the patient, yeah, it's okay, you don't need that. Let's monitor it for another month. And if you do, you can, but probably not. So we also try to avoid ED visits. We give them contact information. So if you need somewhere to go, or if you're concerned, email us, call us, do these things. Family support. We also try to offer a lot of family support and talk a lot to families about the fact that they're going to need support. They're going to need home health. They're going to need, everybody in the family is going to have to chip in for a while. And that as the person who was standing at the bedside for the last 85 days, it's okay to take a day off, right? But sometimes they have to be told that. And that as a good provider, it's just like parenting, and it really is for some of these people when they first get home. It's round the clock, physical, cognitive care. So. And I always tell people, I want you to stop right now and think, if your loved one, as of tomorrow morning with no warning, needed you to be at their bedside for the next 63 days, how would you make that happen, right? Their whole lives are in disarray at this point, not just the life of the patient, but the life of the whole family. The bills aren't getting paid. Nobody's painted the house. Everything that was supposed to happen kind of gets thrown out the window. So Darrell, after the ICU, he showed up in clinic in a wheelchair, super anxious, super short of breath. He got pulmonary rehab. We did lots of counseling, lots of neurocognitive, and eventually realized he couldn't go back to work. So he tried, he really did, but he had such horrible anxiety about failing or hurting somebody or not being able to do the multitasking that he used to be able to do, that he literally couldn't come out of his office. People would come when I can't come down to the floor. I can't do this. So he still struggles daily with memory issues and his inability to physically do things, but he got a therapy dog. And he actually is now, we've started a peer mentoring program. So he actually comes up to the hospital 1 day a week and volunteers. He goes to our social workers and they give him the names of patients who are currently in the ICU and families and says, this person is pretty sick. Why don't you go talk to their family? And he goes in and just says, hey, I'm Darrell. I was in the ICU. I've been through this. Do you have questions? Can I help you? Gets him a pillow, talks about the recovery clinic, whatever. So it's been super beneficial for our patients to have somebody to talk about what's it like to go to the LTAC. Because I go to our LTAC, but I've never been a patient there, so I can't give the same exact representation. But it's also nice for him. He feels like I can't go back to work, but I'm actually making a difference. Darrell also has become an avid surviving sepsis advocate and goes around the country with Carl Flatley, who's the guy who started the Sepsis Alliance, and is speaking on sepsis and ICU recovery and things of that nature. So he has made his new normal okay. There's Darrell. So he likes to hunt. And he told me when he was in the ICU, he said, I'm going to stand on my head again. You just watch. So he was going out to dinner one night or doing something with his wife for some event, and he stood on his head and sent me a picture. So. And then David. So he came to the clinic in a wheelchair, emaciated, frustrated, and deaf. He couldn't hear. He couldn't talk. He couldn't communicate. And he's like, I can't go back to work and be an administrator if no one can communicate with me. So he eventually had cochlear implant and regained some hearing and could communicate. His kidneys recovered, although we're still monitoring them pretty closely. He had partial amputations of his feet and toes, but 12 months and 16 days after his admission, he ran a 10K. So, and returned to work full time. And every year on the anniversary of his admission, he and his wife send flowers and stuff to the UK ICU. So every year I'm reminded of when he came. So yeah, good people. There's David and his wife. So the Society of Critical Care Medicine, through the Thrive Initiative, has developed this ICU Clinic Collaborative. It used to be 8, now there's 15 of us participating. We sort of get together once a month via Zoom and talk about what's happening with our clinics, what are our struggles. We're trying to put together some information so we can publish it and say, this is what ICU recovery clinics look like around the country, trying to create some toolkits for people to help with starting your own ICU recovery clinic. So, but we're also trying to address the post-intensive care syndrome, promoting the use of this transdisciplinary model that's really worked well for a long time in the United Kingdom, and then doing some data collection too to try to convince administrators that this is actually beneficial to everybody involved, not just the patient. So for more information on ICU Recovery Clinic, so this SCCM.org, and then this is myiccare.org. This is a great place I send all of my patients when they're in the ICU and post-ICU. There's lots of good information on PICS for families, some videos, some handouts and things. So just to sort of talk about what's it going to look like after this? Where are you going to be? And how is that going to happen? So questions? Yes? Thanks. Okay. Yeah. Mm-hmm. So what I would tell you is that is a very controversial subject. I am an early tracher. I think that tracheostomies, I tell my patients all the time, Catherine Zeta-Jones had a trach. It did not appear to impair her life long-term at all, right? So just because you have a trach doesn't mean your life has to be changed forever if it's done well and cared for well. I think having a tracheostomy allows the patient to be more awake and use less sedating medicines earlier because you don't have the thing in your throat gagging you, right? And it makes you more human. When you walk in the room and you see the patient with the tracheostomy, they're moving their mouth, people are engaging them, all that stuff hanging around your face, and everybody's constantly freaking out that you're going to self-extubate. With the tracheostomy, the nurses, the staff, they're not as concerned. And I think for early mobility, a tracheostomy, it's easier to move the patient and do things when you're not having to worry about the head altering the positioning of the tube. Now, I will say that that is my opinion and that there is some evidence that maybe it doesn't really affect things and that with the laryngeal injuries and things of that nature that can occur in tracheostomies, that avoiding a trach is best. I would agree. If you come off the vent in 3 days or 4 days, that's what you should do. You shouldn't trach a 3 or 4 day person. But at 7 days, I start talking about tracheostomy early. And I tell my patients, I'm an early tracher. It's what I do. If that scares you, we don't have to do it. But I think it will improve the patient's long-term outcome. And that's always what I'm looking at is where are you going to be in a year? Yeah, this next 6 months is going to be awful. I can't make it any less awful. But what I want is for the awful to actually benefit you long-term and get you better. So that would be what I would say. But it's controversial. So, yeah, I agree. I trach early. I always tell people, just don't even intubate me. Just trach me from the beginning. If I wake up with something shoved down my throat, we're all going to have to deal with my delirium. So, yeah. Oh, no, it's not. No, we have trauma surgeons, CT surgeons. There's lots of different groups. PICU, lots of peds people involved in the Thrive group. So the ICU Clinic Collaborative, actually, it's international. And some of the ICUs, like we have a group in Brazil, and their ICU model is if you're an adult and you're sick in an ICU, just one ICU, everybody, surgical, medical, everybody. So we don't have as much exposure with the neuro group for a couple reasons. Two, because they tend to be a different population, and because a lot of those patients fall in the stroke category and there are already so many resources for them that trying to get them in to get another position in another group is challenging. So. Right. And that is part of the reason. Are you asking who pays at UK or who pays it just in general? Yeah, my division. So I have grants to pay for many of them. My nurse practitioner, so my physical therapist is getting his doctorate right now, and he's doing some research, or some of his time is protected research time, and he's doing some things on ICU acquired weakness, and so he uses some of that time. But then my division is paying for the majority of what's happening there. But we bill for it from a physician standpoint, and we're billing for physical. When he does direct physical therapy, we're billing for it. When I see patients, they're all level 5, so I mean, I'm billing for them. My nurse practitioner also happens to be a dietitian, and so she can bill for some dietary stuff, and she can bill when I'm not there. So like we had clinic yesterday, and I was only there for part of it, and she did the rest of the billing. So I mean, I don't want to say the clinic is self-sustaining, but it's not a complete gift, right? We actually do have some money that comes into the clinic, and these patients are complex. So part of what we have done is gone to our administration and say, from a healthcare utilization standpoint, if they don't get readmitted, if their lengths of stay are shorter because you actually have somewhere to refer them, and if they can see me versus 16 different specialists, maybe that's better, right? And then we can get the other people into the clinic. So we're working, and that's part of what we're doing with this, the collaborative through Thrive 2, is trying to say to administrators, this is what we should be doing because it's going to benefit the hospital infrastructure financially. If we have a collaborative group who can help take care of these patients, then they don't get readmitted to the hospital, which is not where they need to be. But I had a patient who, he had a tracheostomy. The tracheostomy was removed in clinic, and he went home, no problem. 2 days later, he had a tiny little bit of bleeding at the edge, and he said, I think I rubbed it too hard. He went to his local ER because he couldn't get a hold of us, and he was like, my trache's bleeding. The ER doctor was like, oh my gosh, your trache's bleeding. And then he heard his history, because we give him a little pamphlet that says, I have had these things happen. Put him in an ambulance, shipped him 60 miles to the University of Kentucky emergency room as a direct transfer. The ER doctor called me and said, because he knows me, and said, can you come down and see this guy? I don't really even think he needs to get admitted to the hospital, right? I mean, think about what could have happened there as far as prevention of resource management. And he didn't. Like, I literally, it was like, just hold pressure and go home. You're fine. You don't need anything. He just was bleeding a little, but everybody panicked. So we're trying to model it from a resource utilization and length of stay and readmission stuff. Thank you for having me.
And for all of our guests, I'll send you home.
Oh, my son's going to be so excited.
IFT. So it says Ashley, Montgomery-Yates, Medicine Grand Round, University of Louisville, January 2019.
Wonderful.
Jason comes down and takes. Okay. So what you have is such a microphone that only to gauge my academic goals. And then get on that side, and then you know, and then I'll realize, oh my God, that's fine, but I don't have this, this, and this. So I have many patients. I really have no idea. I mean, how around. This was very. I did my part of the job. Yeah. Right.
you're the first person to be like, we have to stop. Why is that? Because I see what happened. And I see that my 51-year-old couldn't go back to work, still struggles with PTSD, is still struggling every day with daily function. And I'm like, if he can't do well, what are we doing? And if I did less of this, I'd have more resources to help these people, right? These are the people that we need to be helping and get back. And we spend so much energy on this inpatient stay, on the sexy medicine, right? Everybody's going to go to ECMO, everybody's going to do all this stuff. And the truth is, if we spent half that money, we would have millions to spend over here in helping people actually refunction. So I agree. And we struggle as a group as part of what we do a lot of. We see the patients in the hospital, we talk about a lot of collaborative work with the families. And then when they go to the LTAC, in town, we actually go there and see them go to the rehab hospital. The problem is if they leave that rehab hospital and they go to the nursing homes don't always want to transport them to all these other clinics. They have a doctor there who's very difficult. Like it becomes this whole, they kind of fall track. And it happens a lot. Or they live in rural Kentucky and it's a 2-hour drive and they have no car. What do you do? I mean, yeah. I also think that if we have more evidence about the long-term outcomes, all of us walk say, I know that yesterday you had a conversation with him, but he said, this is just going to prolong what but I think it's hard for us to say that because we don't necessarily have the evidence. You're welcome.
Hi, I'm Arnold Abdul. I just want to actually, I've been working at this hospital on major for some of our survivors.
Yeah.
I had a collection of ladies, mostly ladies, poor guys who would literally every 4 weeks. Yeah. Sometimes they're ICU stays, sometimes they're on the vent for a day or two, sometimes they're on high pass the entire time. Very poor social support. They had a lot of home
They were going to be back.
That they were going to be back. They couldn't figure out their meds. They weren't strong enough to help them. The therapist comes in 1 or 2 times a week to help them out, and literally you can time it that they would be back. And the hospital's like, well, you're not going to fix them by keeping them here any longer. You got to bring them out.
Right. Yeah.
And
and to some extent they're right, but the problem is now they have this critical illness myopathy, polyneuropathy, and you're like, I can't. So the problem is we don't really know what to do with that population, and we don't know what to do with it in the ICU population 8 or 10 months out when they still have polyneuropathy. How do we help them? What can we actually ask? And we don't have that answer. There's been lots and lots of work done in nutritional changes, in all kinds of supplements, specific motions and movements and this and all this. Nothing has really shown statistically significant.
Is there any biomarker of critical illness myopathy? So you can do a test on your patient on day 2.
EMG
say this patient is at higher risk for lots of complications. Or anything about it, at least we know.
EMGs, that's what we do. We now have inpatient EMGs, and we can get EMGs on days 2 or 3 of inpatient, and then we know people who are at increased risk. Now, here's my problem. Okay, I know you're at increased risk. What do I do? So, I mean, it's one of those things I can diagnose it, but I can't do much else.
Picture we can take. So pulmonary picture.
Yeah.
Dr. Rain's good.
I wanted to introduce Dr. Allen.
Hey, nice to meet you.
This was one of our fellows, now he's faculty, and then interest in the clinic. So we're going to meet you.
Okay, great.
Kind of go back to the
All right, let me just move this.
I'm slightly trash. I think you should stay in the back. I'm just going to say. In the middle. You're in the middle. I don't know where that is. On here?
Yeah, right over here.
Oh, God, I'm not sure how it's at. Yeah, and they kind of hold it just a little higher.
A little higher?
A little bit higher.
Yeah.
Please don't let me hurt kids.
Dr. Bobby can just move to this little thing. All right. Gonna flash. Don't move, don't flash. Here we go. 1, 2. And then we get one. Actually, Dr. Sadi one. Dr. Bobby, hold on one more second. Okay, here we go. 1. Hold up just a little high. There we go. Here we go. 1, 2. Perfect. And now we got a
fashion over there. That's, you know, that's. All right, yes.
you in
the back.
Oh, I gotta get the bag.
Oh,
Yeah.
Me in the bag, huh?
Come on
Okay.
over here, Alex.
So Dr. Shaban and Dr. Morris, you got a bat now.
Okay, great.
There we go. 1, 2. Perfect. Thank you so much.
No problem.
Let me box that back up for you. The good news is you didn't fly, so we don't have to. You can take it. Just take it on home with you.
Oh, good. Oh, if you fly, you can't take it?
Yeah, but they can't check. Actually, they won't check.
Check up that.
Really? I mean, obviously you can't sit there and carry it on.
So you know what you should do? You should just buy people the poster tube and stick it in a poster tube. They never know.
People check golf clubs and stuff.
Yeah.
That's yours to take. If
Thank
you
you
want to,
very much.
take that with you.
Sure.
Go to the Lawrence Airport.
I'm
It's an
good.
airport.
I have multiple learners.